Hello, and welcome to the Insights to Impact webinar series. My name is Lucia Vaz, and I am the Senior Director of Hospital Marketing. I am hosting this as well as Jason Daniels, who is our co-host. He is the Senior Director of Market Access globally. We are really excited about this opportunity to share with you focusing on clinical, operational, and financial strategies to support developing a robust neuroscience service line program. In this webinar, we will discuss various strategies that will be able to help support your program development. With us today, we have Dr. Jeremy Heit, who is the Associate Professor of Radiology and of Neurosurgery and the Chief of Neuroimaging and Neurointervention at Stanford University. He has authored over 200 publications specialized in treating stroke, aneurysm, and image-guided procedures. A great fun fact about Dr. Heit is he is a former state champion in gymnastics and diving in Colorado. Welcome, Dr. Heit.
Thanks for having me.
We also have Debra Philpot, who is a nurse turned administrator who has spent the past 20 years serving in a variety of leadership roles and currently is the VP of Neuroscience and Telehealth Service Lines for HCA TriStar Skyline Medical in Nashville. Fun fact about Debra, she has studied martial arts and has a black belt in Taekwondo. So welcome to our webinar series. Unfortunately, today, Dr. Samir Kumar, our Chief Medical Officer, who was representing our financial strategies from Alexian Brothers, could not join us today due to illness, but we're very appreciative that he has allowed us to continue to use the data that he would be presenting and sharing with you today. So with that, I'm going to turn it over to Jason, and he will kick us off.
Fantastic. Thank you, Lucia, and welcome everybody. This is an exciting webinar. We are thrilled to have both Dr. Heit and Debra Philpot, our experts in the neuroscience service lines, speak with us today. The three topics that really shape up any service line, let alone neuroscience, is really the importance of having the key pillars of clinical excellence, or the ability to measure the clinical impact on patients. Second is operational efficiency. That's removing friction from systems and reducing the time to make treatment, triage, and or transfer decisions. And the third pillar, which we'll talk a little bit about today as well, is the financial viability. That's achieving a measurable return on investment or maximizing your investments. So let's go ahead and jump right into the webinar. First, before we get into the discussion with our attendees here, we're going to talk a little bit about the journey that Rapid has been on over the last 15 plus years. As many of you may know, Rapid was really born out of academia, really by clinicians, for clinicians to solve a clinical problem. And that problem was to expand the treatment window for patients who needed life-saving treatments for their strokes. So over 10 years of R&D led into several landmark trials that helped inform and support the changing of the guidelines for stroke, which expanded the stroke treatment windows from 6 to 24 hours. As you can see on this slide here, Rapid got very busy from a commercial standpoint and led the nation and led globally with its footprint with clinical AI. As of today, RapidAI is installed in over 2,200 hospitals across 100 countries. They've completed over 15 million scans. Over 400 publications reference the work that Rapid has done, 11 of which are in the New England Journal of Medicine. An important fun fact is that over 75% of comprehensive stroke centers in the United States rely on RapidAI for its solutions. So with that, let's now jump into the discussion with our presenters. Let's start with clinical excellence. So as we think about clinical excellence, the first question is for you, Dr. Heit. And that question really starts with this. With many new AI-based algorithms coming to the market, only a few of them go beyond simple triage and notification. Would love for you to expand upon how RapidAI's deep clinical AI algorithm has helped you personally impact your patient care as a neuroradiologist at Stanford.
Well, thanks everybody for having me, and thanks Jason for a thoughtful question. So I think there's a lot to unpack with that question, but let's start to think about it in terms of some framework. So first off, technologies that notify physicians, very helpful, right? It's getting busier. We need to be made aware of things. So I don't want to take too much away from that, but that's not quite enough to really help you make a quick decision. And I think really the best way to talk about that is to think about the information that one gets from, Rapid's perfusion platform, for example, right? So what is that going to do for us? Well, okay, number one, it's going to alert me that there is a problem that's actionable. It's going to tell me that there's a thrombectomy candidate because I can actually see that on the imaging very quickly in a really succinctly summarized manner. Great. But I'm getting a lot more information out of it that lets me take a deeper dive into what's going on with that patient, because I can then tell, okay, well, how big is the core? Is there salvageable tissue? How much salvageable tissue? I can look at the imaging and see exactly where these different compartments of brain are affected. That may have some implications when I think about, should I treat this patient? Should I not treat this patient? When I'm looking on my phone and this imaging is not at my hospital and I'm being called to consider transferring a patient, that level of detail becomes even more important, because perhaps it's not a patient who is going to be a good thrombectomy candidate, and there's no need to necessarily uproot them from their community and their local hospital to come, to my shop at Stanford or to any other shop that the patient would be transferred to, if you're not going to do anything different that would be offered at the local hospital. So just getting an alert doesn't tell you all of that information. You need a more, in-depth dive into what's going on with the patient.
Fantastic. Love that. So Debra, I got a question for you as it relates to operational workflow. Leading a busy neuroscience service line across multiple stakeholders and multiple sites, everything from transferring spokes to receiving hubs, it needs to run efficiently and ideally with the least amount of friction when integrating new technologies like artificial intelligence. Would love for you to share how RapidAI has helped you personally and professionally improve the operational workflow across your service line.
Yeah, thanks for the question, Jason. And when I think about operations in the clinical world, I think about people, I think about process, and I think technology. And so if you isolate one of those things, it's not going to get you the most efficient process. So you have to have the right technology, you have to put it in the right hands of the right people, and then you have to optimize that. It has to be actionable and useful and efficient. So when you think about how we have used this, it's about driving decision-making to the right person at the right time. And that helps us drive the right appropriate care, makes us make the right decisions. And at the end of the day, it's about having the best outcomes for our patients.
Wonderful. Thank you for that. So next topic is we're going to now move into the bottlenecks, the common bottlenecks of stroke care. And so as you can see on the slide here, this is a nice illustration of the common bottlenecks that exist for patients who arrive at the ED and actually move through the system before they actually seek care for stroke. What I wanted to do here is just highlight on the fact that every minute matters in stroke. In fact, every 15-minute delay can lead to an incremental 2% increase in mortality. So I'd like to point this question to you, Deb. As we look at the typical acute stroke patient pathway here, there are multiple bottlenecks and care challenges that can impact the time to treatment. So knowing that every minute matters and that every 15-minute delay can lead to changes in morbidity and mortality, how has RapidAI and technology impacted your service line's ability to achieve more timely triage, transfer, and/or treatment decisions?
Yeah, I can't tell you how passionate I am about this topic. As a person who served a lot of years trying to streamline the efficiency of care in stroke, the biggest barrier that we have seen across different stroke settings, it's not just the primary centers, a stroke ready center, a comprehensive center. It really impacts all of our centers, and that is from the arrival to the decision. So that is the piece that takes the most time and it creates the most delays. Once we actually make the decision, then it can move a lot faster, particularly in a comprehensive center. So the main bottlenecks that we've identified is that arrival to detection and arrival to decision. And the way Rapid and similar technology has helped us identify that is we're not waiting on someone to call us. Again, we get those push notifications, and then we can act on them in a much more timely manner. Rather than coming and pulling the data from some other report, it's actually being pushed to us. So we're able to make a clinical decision more quickly. The other bottleneck is door to transfer and then ultimately the treatment. So having technology at all centers allows equitable care, so that, again, it's about detection. And then you can eliminate bottlenecks by putting a sense of urgency on patients that need to go from one level of care to a higher level of care. So getting those alerts at all levels, the sending and the receiving, really help expedite the care and help coordinate the care, so that when the patient does arrive at the treating facility, we're ready. We're waiting on that patient. We know what the information that's coming our way in terms of the very specific details in their scans, including perfusion. And so we're ready to treat the patient. So the technology really helps us make the decision quicker. And then once we've got the decision made, it helps us deploy the right people and to provide the best care.
Fantastic. So Dr. Heit, same to you. I would love to get your perspective as a neuroradiologist. Can you share, in neurointerventionalist, can you share with us how RapidAI has impacted you and possibly your staff's time to decision making?
Yeah, so I think Debra really did a very nice job of pointing out how critical this is and how critical this is to complex hospital systems of, all different flavors that are out there. When I first started taking care of stroke patients, you would get a call from a hospital, and it would not be your own hospital, and they would kind of say, "We've got a patient, it looks like they have a stroke," and you'd ask, "Well, I can't see the imaging, what does it show?" And they would often not yet have necessarily the radiology report. It would be an ER physician says, "Well, it looks, I don't see any hemorrhage. I don't see any obvious signs of a stroke here." And, so you're making transfer decisions kind of based off of talking to people without seeing the imaging yourself. And there's inherently limitations to that. And there's also more limitations if you kind of say, "Hey, can you see what the radiologist thought? Are they seeing any early ischemic changes that maybe you're not appreciating?" All those things add delay. So fast forward to 2024, now my phone dings. I know that at a common referring hospital that we have a relationship with, there's a stroke patient in the ER, and I know before the ER patient knows what's going on, ER doc knows what's going on. It's just that quick. So we can actually call to another hospital and tell them, "We need to get this patient here," before they've even gotten the patient back from radiology half the time. So think about the time savings that occurs. It's very, very real. And it's really expedited our ability to make good transfer decisions. The fact that this is a mobile world, we're all on our phones all the time, medicine needs to adapt to that too. And that's what Rapid does really well through the app. And so I think that this is an area where the modernization of medicine is kind of outpacing a lot of the other things that we do, which is very fun to be a part of. The other thing I'd point out that I like about this slide is you can see how there are multiple steps and there are multiple software applications that Rapid's come up with to address different points of it. So not only is that useful for the whole host of different questions we're asking about a stroke patient or a transfer patient, it has another benefit, which is it's another layer of a second check, right? So if you're in an academic center, which is where I practice, I think you get really good care because you're going to have a resident and a fellow and a faculty. You have multiple layers of eyes on scans. And so as Debra nicely pointed out, if you're out more in a community hospital, or particularly in an underserved hospital, you don't have that luxury of such redundancy. And that inherently will introduce a greater chance of you potentially missing something. And so the software also kind of acts as that second set of eyes on every study that will help you pick up a problem and pick it up quickly. And I think that does kind of democratize some of the advantages that larger centers have to centers that might relatively be underserved, which I think is a really admirable application and benefit of the software.
Fantastic.
And Jason, if you don't mind, I'd like to just add to what Dr. Heit is saying. If there are many systems of care and systems of stroke care that utilize teleneurology, And we have a program where our teleneurologists are also proactively getting these notifications. And just like Dr. Heit was saying, they're getting that same, say, LVO alert. That ER physician is off with another patient. They've moved on to another septic patient, maybe a STEMI, suturing another patient. They're sort of maybe moved on from a thrombolytic decision, and they're a little bit, eyes are off the ball. But if a teleneurologist or a neurologist at a comprehensive center does have their eye on the ball, we continue to keep moving in an assertive, aggressive manner in terms of that treatment guideline or that treatment timeline. So I think I just want to kind of add that one thing I think is a best practice is for you using a teleneurology services for telestroke or other neurologic deficits, that they become an integral part of leveraging the technology. Again, it's about putting the technology in the hands of the right people at the right time. So I wanted to point that out.
Fantastic. No, thanks for adding that. And we'll be getting into that here in a moment as well. We'll have a chance to double click on that. So now I'd like to move into the first phase of that journey, as you guys saw a moment ago, of ruling out the head bleed. And whether we're talking about the rapid ICH module, the rapid hyperdensity module, or the SDH module. I'd like to pose this question to you, Dr. Heit. As you consider treatment decisions for your hemorrhagic patients, there's many criteria that go into the courses of treatment that you're taking. Would love for you to share the importance of having a solution that, again, goes beyond triage and notification and provides critical information for you to treat this critical patient type. Would love for you to possibly touch on the challenges of manually calculating ICH volumes, having automation at your fingertips, and how this can change not only your workload, but also patient outcomes.
Yeah. So this is another really good demonstration of the utility of how artificial intelligence is starting to integrate into healthcare and particularly into neuroradiology applications. So look, your first example there, where you're seeing the rapid ICH and it's saying, hey, look, hemorrhage detected, intracranial hemorrhage is detected here. So that's important, right? And that's super useful, particularly if you're in a super busy ER, if you've got, a skeleton staff after hours, if you've got some, not in-house neuroradiologists, et cetera. This is a way to kind of flag these actionable cases quickly and make sure they're triaged up on a work list, because frankly, every study in an ER is stat. That's a very common thing. And so it's hard sometimes to up triage, which scan do you really need to deal with first, because they all are really, really important. So I think that detection is really helpful. And it also, again, ER volumes for radiology are just going up and up and up. And so that makes it harder and harder to see things. And I do really wonder if, we're getting into an era where we're going to need a second set of eyes to just help us out, because it's increasingly challenging for radiologists to handle the workflow. And so tools like this will help, right? That's that second set of eyes, and it's going to help you identify something subtle as well. Okay, so that's kind of that part. So let's talk a little bit about quantification. So as the radiologists are getting busier and busier, you don't want to be spending your time doing stuff that's not the best use of human capital, right? Doing a task that we can all do, but it's a little bit tedious and time consuming. I don't want to do that. I don't want to have our other faculty doing that. That should be automated. And this is a really good example. So for intraparenchymal hemorrhage, for instance, even though this is a ventricular one we're looking at, whether that's a surgically evacuable, that's becoming a really interesting area after the ENRICH trial, where they actually use the volume of the clot to guide surgical evacuation treatment guidelines. And so if it were, bigger than 30 mLs, it seems like it could benefit from surgical evacuation. But how do you know it's bigger than 30 milliliters? Someone's got to do the math, right? And so you're showing exactly how we do that math. You got to measure a multiple, find the best slice, get the biggest diameter and cross section, and then you got to count how many slices it covers, and that's going to tell you, with the width of it, what's the volume when you do the ABC divided by 2 method. So certainly, we're all intelligent people. We can do the math, but why waste the time versus having something like rapid hyperdensity that just does it for you and the number's right there? I mean, you can see right here, we're looking at this, you know, you got this 81 mLs, 94 mLs. It's just telling you exactly what the number is. And if you're doing serial scans, you can actually even see what the change that you're seeing between the hemorrhage volume. And that may potentially be something that's actionable too. If it's initially a small volume hemorrhage that grows, maybe the neurosurgeon would say, oh, okay, that's not good. It's been a short period of time. The hemorrhage is getting bigger. I need to, to do something about this. So I think this gets into the era of really helping do tasks for us that we should be using our brains to do other things. And I think that's a really useful thing. And we need to have more of that, frankly.
No, that's fantastic. So staying on the same topic, I'd like to point this question to you, Debra. As a service line leader, you're encountering Joint Commission surveys. One of the topics that comes up often, I'm sure, is the importance of capturing ICH scores and ICH volumes. So where could you see a technology like hyperdensity that automates and quantifies this important measurement for helping you with Joint Commission and accreditation and certification?
Yeah, so certainly the Joint Commission does come up with standards, but the ideal of the standards, I think it's important to start with a why. Why is it important to know the ICH score? The ICH score is a severity score that certainly takes into account not only the volume of the blood, the location of the blood, the patient's neurologic status, and it helps us prognosticate on the outcome of this bleed that we're seeing. But it also, as Dr. Heit alluded to, helps us make informed treatment decisions. So the Joint Commission thinks it's important that the highest level of stroke care in a comprehensive center, that we need to be assessing these severity scores, and we can't just do it at our leisure. We need to do it within 6 hours of that patient's arrival or before we're going to provide an intervention on this patient. And honestly, it's been a struggle because in some facilities, these patients go straight to neurosurgery. And some, they kind of stay with neurology on the medical side. And so it's been challenging to identify who's really going to own looking at the scan, doing the measurements. Do you collaborate with radiology to get that? Then you're waiting on them to actually do that calculation before you can perform all your other examinations and then make a definitive severity score on the patient. But what's really important here is that now this is coming straight to us. Again, we're not having to go pull the information, it's getting pushed to us. And then within the app itself, you can use the different information there. You can put a GCS in, you can have the patient's age, you can enter these type of information right there within the application to quickly be able to capture that severity score, whether it's a patient showing up at your facility, whether it's one that may be transferred to you. Again, is this patient going to need an intervention quickly? Is this patient, do we need to have a conversation about comfort care? If we already know this is just a catastrophic bleed, we can begin to have those conversations very early on. So this has so much utility in this space. In the AI space, we've really focused on ischemic stroke, and that's completely appropriate since that is the bulk of strokes. But this hemorrhagic stroke, it can be very catastrophic if that hemorrhage bleeds and we're not on top of it. So I'm really glad that we focused some more of our attention in the hemorrhagic space, particularly because now we have more treatment options with minimally invasive strategies for these patients that have these neurologic emergencies.
Fantastic. And as you can see on this slide here, here's an example where an institution or a subnetwork out of Nebraska leveraged the hyperdensity algorithm at RapidAI to improve their compliance from 30% to 95%. So here's a real world example of this impacting those score reports. So that's great.
Hey, Jason. Oh, go ahead. Keep going, Dr. Heit.
I was just going to make one other comment, which is the other plus to this kind of thing is it adds consistency, right? Whereas, your radiologist shifts change, people change, so measurements could change from person to person. And there's some advantages to having it just be done consistently with a software that's going to perform consistently too. So I think especially as you're tracking hemorrhage volume, that's going to lead to improved accuracy.
Love that.
And that's actually a really good segue into a question that we have in the chat. How do you ensure that AI integrates into existing clinical workflows without adding unnecessary complexity for the providers? Maybe we can, touch on that a little bit.
Yeah, I mean, I can give you my 2 cents on that. It's really important, right? Because there's so many series for each scan to look at. I know we constantly are debating that as a faculty. Why do we have so many different things? And you don't want to add something else to look at that slows you down. You want to have something that helps you. Okay, and so this is a good example. I think another good example is frankly perfusion software. Again, not to come back to that as the sole example, but what I teach the residents, if it's a stroke patient, don't start looking at the CTA. Look at the perfusion first, because it makes it so obvious and quickly obvious that there's a large vessel occlusion. You can see this big green area. There's a vessel blocked, and in fact, you can infer where the vessel blockage likely is based upon the pattern of the perfusion deficit. So then you're reaching for the phone to call the doc who ordered the study while you load up the CTA and confirm that the occlusion is where you think it is. So that's a good example of, yes, it's an additional set of images for radiologists to look at in a very busy, stroke protocol CT, but it helps you move a lot faster. And same thing for a hemorrhage, right? If you have it and it's succinct and it's only a couple of images, through rapid ICH hyperdensity, you're going to quickly see it. You're going to see where it is in a couple of highlighted images that are the most likely sites where the suspected hemorrhage is going to be present, and even the quantification is there. It doesn't take that long to look, but it clues you in really quickly to what the issue is, and also to the degree of what you're going to have to talk about. So I think that is something that can actually save time, even though you are adding a couple of extra images to look at.
Great. Looks like, Lucia, there's another question in the chat, and the question is the ICH volume part of the current ICH module? And the answer to that question is no. The ICH volume comes from our hyperdensity module, which is a separate module from the ICH module. All right. So moving right along. So now what we're going to do is we're going to turn the corner and move into the ischemic stroke LVO detection using non-contrast. So this question is back to you, Dr. Heit. Coming back to this patient journey and the importance of timely treatment. Many smaller referral hospitals, as we talked about previously, lack some of this advanced imaging capabilities. And oftentimes they don't have the neuroradiologists on staff 24 hours. So how do you see AI playing a role to help these hospitals in particular to both prevent unnecessary transfers and or to provide faster treatment and or transfer decisions?
Yeah, so it's a really good question, Jason. And this slide's nice because it shows exactly the problem. Non-contrast head CT is the go-to study for the evaluation of the stroke patient. Okay, so we all are very familiar with that. It's commonly done, but it is hard to interpret, especially for ischemic stroke. The findings of an acute ischemic stroke due to a large vessel occlusion are subtle. They are easily missed. If you don't have particularly sufficient history, or if you are not aware of exactly how severely impaired the patient is, the odds of you making the correct diagnosis are just lower. And again, you're thwarted by the constant increase in volumes within your emergency department, particularly after hours, et cetera. So having a tool that looks at that non-con along with the radiologist to try to bump up, the detection of stroke with an extra set of eyes, really, really helpful, particularly in these underserved hospitals or hospitals that don't have advanced imaging capability. I'm really lucky. Like, our patients are going to get a perfusion, which is, again, like I was just talking about, it's sort of like a big flag saying, hey, problem. But if you don't have perfusion, because it's just something your hospital, doesn't offer, doesn't have the expertise to do routinely, doesn't see enough patients that warrant it, you're stuck with a non-con head CT. And so you've got numbers here. I mean, I've even heard lower than 41% detection of a LVO on a non-con. It's really, really difficult. So if you can bolster that up, particularly like a 50% increase like you're showing here, that's substantial. And that also really helps make the correct diagnosis quickly, because otherwise figuring this out on a non-con is really tricky, and that certainly leads to delays in care.
Fantastic. So Debra, I'd just like to come back to you as well. I know you speak a little bit about the teleradiologist and talked a little bit about some of these rural centers. Could you speak a little bit to the addressing this time of day issue, at midnight or on a weekend, and where you maybe see this non-con LVO solution playing a role?
Yeah, so Jason, one of my passions is that when I think about rural healthcare, we know that if you're having a stroke in a rural area, you're more likely to have a mortality just because of the access to care. So what I want to do is make healthcare equitable. If you're having a stroke in a rural facility, you should have the same chance as someone having in an urban location. And so with this technology, you have sort of the bottom rung of the ladder in terms of neurodiagnostics that everybody has. A freestanding ER has it, a rural hospital has it, primary. So everybody has this technology. So then you can take out some of the disparities in care just because you don't have the resources. And it really escalates the quality of care. So I was looking at some images today, for example, a great ER, and they had a patient with an ischemic stroke, and they were right on top of it. They got teleneurology. They were able to treat with thrombolytics, and then they put the patient in the ICU. Going back, they did a CT angiogram and then found a very distinct occlusion in the middle cerebral artery in the first segment. Then looking back with more expert eyes on the non-contrast, there was an MCA sign. And so, not to fault the care that was provided, they recognized the stroke, they treated the stroke, but they missed that MCA sign that's shown here in that top picture on the right-hand side. I can see that. I'm used to seeing it all the time. I've been doing this for a while, and I'm just a nurse. But if you're those that are seeing all kinds of patients and in different types of facilities, you might miss that. So this technology is really important. Again, it provides equity of care no matter what location you're in, no matter what hour of the day, what resources you have. So super excited to have this technology to give that patient an extra chance.
Just to bootstrap to that too, Debra, because I think one additional point that to point out is not every patient with a large vessel occlusion has severe symptoms. All right, and I'm sure you've seen this in your center. I've certainly seen it in ours, where you have a large vessel occlusion, the stroke scale is 4 or 5, and that's sort of a gray area where we really don't have good evidence that that patient should be treated with a thrombectomy. So maybe exactly what you describe happens. They go to the ICU, then they decompensate, and then you scan, you get a CT, like, oh my goodness, there is a large vessel occlusion that we weren't really suspecting. We thought it was a deep stroke. Now we got to transfer the patient. Versus you pick that up more quickly with, assistance with software like this. You call, the comprehensive center, and, the team there might say, just bring them here because there might be a high chance of decompensation. We'd rather have them here when that happens. Or maybe the center that you would go to is willing to even offer treatment even with a more mild stroke scale. So those patients are out there, and you want to figure this stuff out sooner than later.
That's great. So Lucia, just checking in, do we have any questions on ischemic stroke before I transition into cerebral aneurysm?
I think we're good.
Okay.
You can move on to the next section.
Excellent. So now let's change directions a little bit. We're moving now into cerebral aneurysms and talking about some of the most common care challenges. As many of you know, aneurysms can be hard to find, and oftentimes they're overlooked. In fact, 15% of cerebral aneurysms are missed in the United States with the current standard technology. It's these inconsistencies and inaccuracies of detecting growth that also can be a challenge, especially with this manual measurement. 5% of aneurysms grow on an annual basis, and when the growth begins, this leads to a 12x increase in their rupture risk. And the growth isn't typically always linear. It's the morphological changes in growth that oftentimes can be missed with standard CTA and MRA imaging. And last but not least, the third challenge that's on this slide that we'd love to talk about as well is keeping patients in your network. It's these patients who have these unruptured aneurysms that are slowly or inconsistently growing over time that oftentimes get lost to follow-up. In fact, 22% of these patients are lost to annual follow-up, according to the literature. So as we talk about cerebral aneurysm, let's jump into the first set of questions, and that comes to you, Dr. Heit, once again. We want to talk a little bit about cerebral aneurysm detection. But more importantly than detection, we also want to talk a little bit about the monitoring over time as well. How do you see a solution like RapidAI's aneurysm playing a role in helping you and your colleagues overcome some of these challenges I just shared?
Yeah, I'm really excited about rapid aneurysm. I think it's great to see the company, getting into the aneurysm space, because everything you just said, Jason, is completely true. So, first off, detecting a big aneurysm, generally we're pretty good. Detecting multiple aneurysms, sometimes we're not quite as good. Detecting aneurysms near the skull base, sometimes we're not as good. Detecting aneurysms when you're increasingly busy, the odds of missing it, if it's only on 2 images, it's just inherently going to go up. So one anecdote I can also share about this, I was involved in one of the first studies with rapid aneurysm, and we did a little pilot. And so we had very good neuroradiologists, and we read some CTAs, and then we compared it to rapid aneurysm. And we had this in the pilot, a few cases where we're like, oh, rapid aneurysms, it's false positive. It's calling something that's just not there. So then we looked at it as a group, and I was like, that's an aneurysm. So rapid aneurysm was right. The neuroradiologists, including this guy, we were wrong. And so then we had to actually think about how we're going to design the study to make sure that we didn't end up with this, what you would deem a false positive when the software is right and the gold standard's wrong. And that was really eye-opening for me. And you can kind of see why that might be with these images you've got shown in front of you. Rapid aneurysm is going to take the CTA or MRA data, and it's going to give you these 3D views that really looks exactly like an angiogram, as if they were undergoing a catheter angiogram. A catheter angiogram is a gold standard for evaluation of detecting an aneurysm, and the software is mimicking that and applying artificial intelligence techniques to that sort of surface contour to pick it up. So this helps you pick these things up. You do not want to miss an aneurysm. That is a do not miss lesion for neuroradiologists or any other radiologists. So that's really, really important. Now, particularly tracking aneurysms. When a patient has an aneurysm identified, increasingly that's an incidental finding. They have a headache, they're getting a stroke workup for a TIA. They fortunately don't find a stroke etiology, but they find an aneurysm because they are relatively common. So depending on what study you read, 2 to 6% of people out there have a cerebral aneurysm. That's fairly common. But once you detect it, now you need to keep an eye on it. And, many of the aneurysms that are detected are relatively small, and we don't go and necessarily treat aneurysms that are relatively small because we don't have very great data to say that we should be doing that given the risk of aneurysm treatment. We want to find the ones that are big enough, or as you noted in the last slide, growing. Okay, so a patient has an incidentally identified aneurysm. I have a whole clinic full of patients with this exact scenario, and we get surveillance scans. And this does a few things. Okay, so I did this week in clinic. You have a bunch of patients, they want to come in and see you, and you're going to compare your 2 scans side by side. And I like to review the imaging with my patients and show them that their aneurysm, hopefully looks the same. And I kind of put it up and I measure it in front of them and I show them, look, it looks the same. What you run into all the time, the patient gets scanned in a slightly different plane. And so I can look at it and be like, look, it's the same. I can measure it in the right spot. But because they're a little bit off, the patient who may not be familiar with neuroimaging says it doesn't look the same to me. Are you sure it's the same? I think it's bigger. And I spend a lot of time explaining, well, the plane's different and we can measure it this way and this way. We can make reformats in front of it. And it makes the clinic visit take a lot longer. And then suddenly I'm running behind. So rapid aneurysm does all that for me because it allows it to be standardized views. It allows me to co-register, superimpose themselves as you're seeing, and then get actual measurements to show the patient it's the same. All right. And there's some nice papers out there that have also kind of picked up where this is going to show us a little bit different stuff that we don't typically measure that may be really, really important, right? So Dan Saline has a nice paper where he found the aneurysms that were undergoing surveillance that ruptured demonstrated a pretty marked change in surface volume and in area. Okay, so we don't measure aneurysms that way. We do kind of cross-sectional things. We say, look, it's still 2 by 2, great, or whatever size it is. But his observation that you're seeing greater changes in volume and surface area, that may be more meaningful and perhaps something that we should be considering when we're tracking these aneurysms, because you're going to be more sensitive to small areas of growth. Maybe there's a bleb that's developed that is very hard to see unless you're making a bunch of reformats that are, not always standardly done. So I think this is a really exciting tool. It gets at the treatment and care of aneurysms from multiple different fronts. And I think that this is really going to be something you're going to have a lot of docs really liking.
Fantastic. So Deb, now I'm going to turn over to you, and this here just advanced the slide, and you can see now we're looking at this. I think this article you were referencing, Dr. Heit, relative to the aneurysms. But Deb, as you oversee the growth and expansion of your neuroscience service line, how do you see a solution like RapidAI's aneurysm longitudinal tracking of patients playing a role?
Well, first of all, when you think about growth, we do think about kind of business and development and growing your volume, growing bottom line. But I think first and foremost, as a clinician, I think about clinical growth. And so this technology certainly is growth in the technology. It's really taking what we do well and doing it even better. As you look at the examples here, such detailed analysis, and sometimes it's the increase in size, but the morphology, as we talked about in the beginning. But one of the things I really like about this and is that it creates a stickiness with our patients. So if we pick up an unruptured aneurysm, and we can go ahead and contact that patient, they're within our system, and we use mechanisms to reach out to them, go ahead and make an appointment with them, and go ahead and get them on a regular cadence of imaging. And the way that we can engage the patient is such a much more advanced level that it creates more of a stickiness with that patient. And I think that they can really appreciate it. And ultimately, as we monitor these serial subsequent studies, some of these patients will require some intervention, some downstream intervention. So just like those that you may be familiar with long nodule screenings, there are a lot of patients out there that had early signs of, but they were just getting missed. They were incidental findings, and then they would fall through the cracks. This is really a very similar example. We're finding incidental findings, we're connecting with the patient, we're monitoring them, we're tracking them, and then when appropriate, we'll be able to still have that relationship, still be within our network, and provide kind of navigated care. So it's good for the bottom line, but it's good for our patients and our families' experience as well. And that's really adding a lot more value than just counting numbers, counting procedures. We're providing a higher value service because it's a higher touch. It's staying connected with our patient and our family.
Fantastic.
Patients love this. They really do. I mean, imaging is a really abstract thing for a lot of people, but it's a great user interface. It's easy to understand. Patients can look at it with you and get it right away. It's quantitative. I mean, it has everything you want if you're a patient worried about your aneurysm in a way that's really easy to understand. I completely agree, Deborah. This is a really great patient care experience. And for, hospitals and healthcare systems, that's a really good thing.
Fantastic. So now we're going to transition to the next topic, and that is accuracy. With all artificial intelligence, you want to have the most accurate, the most precise. You want to avoid the notifications in the middle of the night that are not necessarily true indeed. And so I'll direct this question to you, Dr. Heit. As you take a look at this figure here, there's clearly some comparisons between Rapid and the competitors relative to the different segments. Would love for you to sort of speak to your experience conducting research and the importance of having accuracy when you need it, where you need it, and regardless of the location of the lesions.
Look, we all would love a test that's perfectly sensitive and perfectly specific. It just doesn't exist, right? You cannot have it all. And so you want to identify what's the best balance of those two things. And, Rapid generally really outperforms substantially on multiple different fronts. But I think particularly something that's overlooked is the importance of specificity. So if you're really sensitive, your phone is going to alert you a lot, right? Boom, boom, boom. So when you look at it, you want to have it be correct, right? You want to have that finding that you're looking at actually be the thing you care about. You want it to be a stroke. You want it to be an LVO. You want it to be, hemorrhage positive. You want it to be detection of an aneurysm. Because the problem is if you look and you're like, oh man, you're taking the time, you're scrolling through, it's like it's a false positive. Like the product is overly sensitive and it's not specific. That's when you can get into alert fatigue and you start to ignore the ding when it comes at you because it's got a higher percentage where it's just not accurate. So I really think specificity is really important to pay attention to. And I think that that's something that we tend to, as humans, really want it to be always sensitive. And what you're seeing with these numbers is Rapid's got really good sensitivity, but the specificity is really, really high. And I think that reflects the thoughtfulness of the company and also an understanding of what over alert fatigue does to physicians. So I think that's an important point.
Thank you so much.
Yeah.
So now speaking of operational efficiency, we're going to now touch on a couple points that are probably true, near and dear to both of you, especially you, Debra, leading a large system and network. So I'm going to go ahead and now turn to the first question for you. This slide here illustrates, some of the time improvements that we've seen with the LVO module here at Rapid. But I want to ask this question of you, Deb. In looking at this case study example, that illustrates the time savings, starting with the non-contrast LVO identification. How do you see a solution like this that identifies LVO from non-contrast images impacting your service line and the time to treatment?
Well, it's hard to even put it into words, Jason. We all know the mantra, time is brain, and it absolutely is true. And as we've been treating patients for a long time, just in the medicine side with thrombolytics, our goal used to be 60 minutes, and then it was 45, and then it was 35, now it's 30, and we're doing it faster and we're doing it safer. So when you can think about reperfusion to an injured brain, taking 18 minutes off, that is just not only cells change, that is lifestyle changes. So that impacts the ultimate, ultimately we're trying to eliminate disability from people's lives. And so minutes equal less disability. So if we can replicate these numbers in so many health systems across our country, and in fact, in the world, we are going to reduce mortality and we're going to produce a much higher rate of high quality of living with lack of disability. So I just can't say how important it is and how valuable it is. To shave off the 2 or 3 minutes off a complex process is a big deal when you're already working in a very lean world. So to take this many minutes off, as this study has pointed out, it's phenomenal and it's life-changing, to say the least.
Yeah, no, thank you, Debra. That's very nice. So now we're going to move to another case study. This actually comes out of an institution, a set of institutions out in the Nebraska area. And this is actually looking at the specific ICH patients. So Dr. Heit, as we take a look at this case example here, where CHA Nebraska was not only able to increase the detection and treatment of these ICH patients, but they also saw some other staggering metrics on here, including the reduction in length of stay by 5 days, improving their ICH score reporting up to 95%. So I would just, love for you to sort of react to this and maybe think about your own experience of how the rapid hyperdensity and or ICH modules have helped you not only identify more of these patients in a timely fashion, but improve patient outcomes. And where do you see this evolving over the next couple of years?
Yeah, I haven't actually seen this abstract, so this is really great to see it in action. It really doesn't surprise me, right? Because you're doing the things you should do, and look at this increase in detection and treatment. That's going to translate to less hospitalization time. It should, right? And so I bet it's even more than that. If you got into the nitty gritty, I would suspect some of these patients probably aren't treated right away, but they're getting serial scans. And I'm going to bet that rapid hyperdensity is kind of indicating a growth in the hematoma that's leading to surgical evacuation. Whereas without that, oftentimes these are serial head CTs are read a little bit more just what the radiologist thinks, not necessarily quantitatively, it's much more qualitative. But if you have a number that shows, hey, volume is increasing, I think that inherently becomes a more actionable thing that you're going to pay attention to, that your eye may kind of overlook. I think, Debra spoke really well earlier about the importance of scoring, particularly if you're a comprehensive stroke center. That's just something you don't want to be dinged on or not doing because you don't have a good documentation system in place. And also part of why you want to have that score is it's supposed to help your treatment decisions, right? And so that's another reason that I'm sure they're getting a good score. It's getting implemented, and that's probably up triaging some patients to treatment, which then leads to a reduced length of stay. So I think this is exactly the kind of data that I would hope other centers start to publish, not only for this specific application, but this underscores the utility of AI in healthcare. And if we're going to have reimbursement codes eventually get attached to these things, we got to show that the value and the benefit. This is a really nice example of that. That's great.
Fantastic. So on the topic of outcomes, this is a case study that actually was presented to us from Dr. Kumar from Alexian Brothers. And this was specifically looking at a 3-year analysis of over 1,700 ischemic stroke patients that came in through Alexian Brothers in the greater Chicago market. And as you can see in this case study, which was presented and published as an abstract, that there was a 30-minute median reduction in the time to treatment for these patients, a reduction from 148 down to 118 minutes. When we look at the volume increase in procedures of 51%, pretty staggering, and actually much larger than we've seen in some other smaller case studies. We wish Dr. Kumar could be here to speak specifically about how this has impacted him as a chief medical officer. But alternatively, I'll turn to you, Debra, as a VP of a service line, seeing this type of data where you're not only improving the time to treatment, which we talked about the importance of that, but you're also increasing, revenue generating procedures that can bring, revenue into your system. Can you speak to how, RapidAI can help you achieve, both an improvement in time, but also an improvement in revenue, and how that would make a difference to you as a VP service line overseeing, 14 hospitals, 15 hospitals?
Thank you. Yeah. So we've talked a lot about the door to treatment time and that side, but I definitely think that this slide here points out that it's the detection of that, of these cases. They were already there. We weren't recognizing them. So it's not all of a sudden more patients started showing up at your door that needed a thrombectomy, but using the technology, you were able to detect them and treat them more often. So the way that impacts is it really does impact the bottom line. So you're taking a patient who would be listed under a medical DRG and then move to a neurosurgical DRG. So significant impact in your net revenue, your contribution margins, however you look at the financial data within your hospital or within your health system. So it's a very direct, it's very easy to measure just on your treatment rates alone and your number that you're treating, the financial impact. And a little on the softer side, but no less important, is something that we talked about in the last slide, and that is length of stay. There is no hospital administrator that is not focused on length of stay because of the implications for turning around that bed. Number one, it frees up the bed for more growth, but it reduces the potential for complications while the patient is in the hospital. And as most of you know, that we are getting paid on a DRG basis. So a patient, you get X dollars for paying for a patient, whether they stay 3 days or whether they stay 10. So it's a measure that's so important to hospitals right now in terms of efficiency when they're trying to manage costs. Right now, we're putting a lot of focus on our labor costs because we need to compensate our physicians, our technicians, our nurses. That's such a valuable resource. So how do you offset that? You offset that by having procedures that pay at a higher rate, and you try to reduce your cost by having lower length of stay. So important as we look at the economics of healthcare today. And we all need to be looking at that, no matter if you're on the clinical side, operations side, or the financial side. There's an impact to every one of us.
No, love that discussion. And here is a great illustration of that, right? Oftentimes we talk about price. That's the tip of the iceberg. It's all these things underneath the surface, the complication rates, the length of stay, the futile transfers, incremental procedures, leakage of patients out of your system. And that's pretty costly if you're especially in a competitive marketplace. And then, as we talked about already, the inefficiency and extra staff time. So what I'm going to do now is I'm going to jump right into, this is the tagline from the Ascension Brothers abstract that I just, Alexian Brothers from Ascension, that Dr. Kumar's own institution, they took all of those variables from that abstract and plugged them into their financial models, and were able to show not only did they optimize the revenue from those procedures of 2.5 million, but they avoided and they had some cost savings by avoiding the hospital length of stay, as you talked about, Deb, leading to an $840,000 reduction. They reduced complications by 50. That translates into about $400,000 a year. And then last but not least, they were able to actually improve the efficiency of their staff by over 625 hours. So the grand total of that abstract that was shared a moment ago, and I wish Dr. Kumar was on today to share exactly how this $4.5 million financial gain has impacted, Alexian Brothers. And you can just think that the impact across, a system like yours, Deb, where you've got multiple hospitals. So I just wanted to share this with you and really maybe ask a closing question of, as we look at these real world examples, can you share with us, Deb, maybe the impact? You don't need to give us the financials, but how have you seen AI, particularly RapidAI in the TriStar division of HCA, helping you improve many of these variables that we see on this slide today?
Yeah, I think it just goes back to, I will just really focus on the treatment rate. So if we're doing the right thing for the patient, we're going to be treating more patients. And it's, again, put patient care first, you do the right thing, and everything else kind of falls in order. But it really is about making sure we're not missing opportunities for patients, that we're treating them under the clinical guidelines that now exist, and we're doing the right thing for patient. You do that, all these financial indicators really just fall in line. And that's really what we can do at each one of our facilities that we work in every day, is do the right thing for patients, and the finances really do take care of themselves in the big picture.
Fabulous. So I know we have just a couple minutes left. Lucia, I'm going to now turn it back over to you to see if there's any burning questions that we may have that we didn't get a chance to address yet.
I think we've answered pretty much all of them through our Q&A session. So thank you so much, Dr. Heit and Debra, for your time today. We know you have busy schedules and lots of competing priorities within the hospital, and to spend an hour with us to discuss, how we can develop service lines to help neuroscience programs really, maximize their current investments and perhaps look at future investments. We look forward to, being able to follow up with our attendees. And thank you all again for your time.
Thank you so much.
Thanks for having us. That was a lot of fun.
Thank you.
Great.